Welcome to Board Pearls. This is episode 4 of 5 of the Colonoscopy Practice and Quality chapter in the Endoscopic Procedures module. In this episode, we cover the post-polypectomy adverse events, delayed and immediate bleeding, the prophylactic clip question, perforation and its closure decision, post-polypectomy electrocoagulation syndrome, and splenic injury. The post-polypectomy adverse event set is taught best by its mechanism, because each event has a distinct anatomic or thermal correlate that determines what you do next. Post-polypectomy bleeding sits first. It runs between 0.3 and 2.5% overall, and the rate climbs with polyp size, with hot snare use, and with antithrombotic exposure at the time of the procedure. The instructive division is timing. Immediate bleeding is recognized at the moment of polypectomy from the polypectomy site itself, and management is mechanical or thermal at that visible vessel. Hemoclips oppose the defect and close the vessel. Snare tip coagulation or coagulation forceps deliver focused thermal energy. Epinephrine injection adds vasoconstriction and a tamponade mass effect, but epinephrine alone is rarely durable and is usually paired with a definitive modality. Delayed bleeding presents 1 to 14 days later in a patient who has already gone home with hematochezia and a known recent polypectomy. The right move is repeat colonoscopy with endoscopic hemostasis on the still recognizable polypectomy scar. Most delayed bleeds are self-limited, but some are brisk and require active intervention. The prophylactic clip question deserves its own paragraph because it is testable, and the indications are specific. A randomized trial showed that clip closure of large EMR defects in the proximal colon reduces delayed bleeding. The number needed to treat is around 10 in patients on antithrombotics or with proximal lesions over 20 millimeters. The mechanism is mechanical. Clip apposition holds the defect edges together, shields exposed submucosal vessels from luminal acid and mechanical stress during recovery, and accelerates mucosal healing. The corollary that the boards test is the inverse. Routine clip closure of small left-sided defects in patients off antithrombotics has not shown benefit and is not standard. The decision is driven by location and risk, not by reflex. Perforation sits on a different mechanism. Diagnostic colonoscopy carries a perforation rate of 0.05 to 0.1%. Therapeutic procedures push that into the 1% or higher range, with large EMR, ESD, and dilation carrying the most risk. Recognition during the procedure shows the muscularis propria, or extracolonic structures through the defect, and that intraprocedural recognition is the moment that decides the next 2 days. A fresh perforation under 2 centimeters can be closed endoscopically with through-the-scope clips, over-the-scope clips, or endoscopic suturing with success above 90% in published series. The reason fresh closure works is that the peritoneum has not yet been seeded meaningfully, the tissue edges are clean and amenable to apposition, and prompt closure prevents the contamination that would otherwise mandate surgery. Larger defects, older perforations, established peritoneal contamination, and defects in pore closure positions go to the operating room. Recognition after the procedure is the harder presentation. Peritoneal signs, fever, leukocytosis, and free air on imaging in the hours to days after colonoscopy are perforation until proven otherwise, and the workup is cross-sectional imaging followed by surgical consultation. Post-polypectomy electrocoagulation syndrome is where careful reading would walk you into the operating room for a patient who does not need surgery, so this is worth slowing down on. The clinical picture is fever, focal peritonitis at the polypectomy quadrant, and leukocytosis 24 to 72 hours after a hot snare polypectomy, and it can look exactly like a perforation. The discriminator is imaging. There is no free air. The injury is transmural thermal damage to the muscularis propria without a through-and-through breach. The serosa is inflamed, and the patient hurts, but the bowel wall is intact. The mechanism is that hot snare current diffuses beyond the resected mucosa into the muscle layer, producing a microscopic burn that drives a localized peritoneal inflammatory response. The syndrome occurs in roughly 0.5 to 1% of hot snare polypectomies, and management is conservative. Bowel rest, intravenous antibiotics covering colonic flora, and observation resolve the picture over 2 to 5 days in most patients. The teaching point is that the absence of free air on imaging in a patient with the right history flips the management from surgery to admission. Splenic injury is rare but recognized, And it earns a sentence because the recognition pattern is otherwise easy to miss. The mechanism is looping at the splenic flexure with traction on the splenocolic ligament, which tears the splenic capsule. The presentation is left upper quadrant pain. It often radiates to the left shoulder as the care sign of diaphragmatic irritation from intraperitoneal blood. Hemodynamic instability and free fluid on imaging follow hours to days after colonoscopy. Management is stability-driven and runs from observation in a contained injury through splenic artery, embolization in a stable patient with active bleeding to splenectomy in the unstable patient. That closes the adverse events, and the unifying frame is that the recognition cue tells you the mechanism, and the mechanism tells you the response. Hematochezia at day 5 points to a scar that can be retreated endoscopically. Free air points to perforation and a closure decision driven by defect age and size. Focal peritonitis without free air points to thermal injury that resolves on bowel rest. Left shoulder pain points to capsular tear and a stability triage. The cues are not interchangeable. The next episode takes the other half of why colonoscopy quality matters. The serrated pathway where missed lesions become right-sided interval cancer, the Lynch reflex testing tree that sorts sporadic from hereditary, and the special population considerations that bend the standard algorithm by one mechanism at a time. For the full chapter, the practice vignettes, and the topic tag question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 4 of 5 of chapter 30, and I'll see you in the next one.